It's social distancing at the chamber, also known as Happy Hour with Hammer. My name is Garrick Taylor. As always, we're joined by the CEO of the Arizona Chamber, Glenn Hammer. Glenn, the doctor is in. He's making house calls. So why don't you introduce our special guest?
We're very fortunate to have Dr. Shah, who serves very honorably in our Arizona House of Representatives. But I would say even more importantly right now is the work he's been doing in the emergency room from the very beginning of the COVID pandemic. And he has written a number of Facebook posts. I realized it the first time when my wife must follow the doctor. She said, "This is a brilliant post. Do you know Dr. Shah?" I said, I do know him. He's actually a great elected official as well. Dr. Shah, welcome to the program.
Thank you for having me and for the really kind words.
And I hope I'm allowed to say this because this may be a little bit like a Quentin Tarantino show where it goes out of sequence a little bit. Mm-hmm. But right before, literally the moment I came on, right across my screen came on from, I think, the Daily Mail or whatever, the UK newspaper, is that Pfizer is going to ask for an emergency authorization tomorrow. Now, am I breaking a state secret that I'm not breaking a state secret because I think you've written about it or you've been on TV about that you've been part of the Pfizer clinical trial.
I am an enrollee in that trial. I got the number from the Arizona Republic. It said, if you want to volunteer for this, here's the number. I called it up. It's the Hope Research Institute. They've got centers all over the valley, I think in Tucson as well, pretty close to my house over at 39th Street in Camelback. And I wanted to know what was going on, what kind of what were the ones that were available, what are the protocols, what are the science behind it. And I chose to enroll. It's something that I think is important for people to understand, that we all do have to participate in research in order for that research to work. It doesn't work unless there are volunteers willing to go out there. I also understand it's not for everybody. You have to understand the risks. You have to feel comfortable with it. And being a physician, it's easier for me to look at the original manuscripts, break down that data, think about what are the side effects, what is the side effect profile, I should say, what are the risks, and then of course what are the benefits, and the benefits mostly accrue to people at large, society, humanity, and so for me, I felt very comfortable in getting in there and enrolling in this trial, and so far so good.
It is. Now, you don't know for sure whether you have the actual proposed vaccine or the placebo. You may have some ideas because you're a doctor, and
that's pretty much correct. I have a pretty good feeling which arm I'm in.
Right.
And it was 2 shots.
Correct. So you go in for the first time, they do the entire screening on you and just make sure you meet all the inclusion criteria. You don't meet any of the exclusion criteria. They draw your blood, they do a nasal swab, and then you get 1 shot in the arm. You're blinded. They tell you to turn your head so you can't see whether it's cloudy or clear, because that'll give it away. And of course, they bring it in the same dry ice or whatever that they have in order to keep it really cold. And they use, they kind of cover up the syringe and they try to do what they can. But yeah, you get 1 shot, and then about 1 month later, you get 1 more. It'll be the same one, right? So if you were in the placebo arm, you get a placebo again. If you get the shot, you get the shot again. And then after that, they monitor you. You have an app on your iPhone, and you have to fill in a little questionnaire. It's a 1-question questionnaire every single week. And then they have these follow-up visits that they schedule for you as well. So that's pretty much the entirety of the participation.
Would you if the emergency use goes forward and the 95, I've been reading 95% efficacy, which is marvelous. I mean, that's at the highest level in terms of if that sticks, and it appears it will, with other vaccines that we now just take for granted.
Pretty good efficacy. Pretty good efficacy, both for Pfizer and the Moderna trial. Both of them reported about the same level of efficacy. So the benefits again are that if it's 95% efficacious and you have not had coronavirus, it will prevent a coronavirus infection in you, we think, for a decent period of time. With both of these trials, my understanding is that the phase 3 trials enrolled 40,000 people each. So you had a total of 80,000 people. And in those 80,000 people, plus the phase 1-2 trials, which had a few hundred in there, so some change. In all those people, we have not seen a serious side effect. That doesn't mean that it's not going to happen. The experience that we have, to put it in context, the experience we have with some of the other ones is millions of doses, post-marketing experience, phase 4 trials, that's what we call those. So it gives you a much clearer picture of how that's going to go. So some people have raised this idea of, well, is there some risk? Yes, it has been brought out, getting close to market here in record amount of time. I wouldn't have taken it if I didn't feel that it was fairly safe and that it was something that I felt very comfortable with. I would say that if they got the emergency use authorization, and don't forget the peer review also, is done to the satisfaction of the medical community, the scientists, that it would be fairly safe for use for the general public. That's why we have all these checks and balances in place, to make sure that that's how we bring something that won't hurt people en masse. And that's a harder thing. I want to bring out one subtle point, is that a lot of times you can look at the risk in a certain way and say, well, it still is fairly new. And I've heard this sentiment from many people. It is still fairly new. I don't know if I want to be the first that I know to go get this thing. And at the same time, you have to consider, what is the benefit? So because the risk of doing nothing is also fairly high, you're playing in a different, you're having to make different decisions. And in the field of medicine, this is what we do all day. There are more risky things that we will do, more invasive things that we will do to you in the hospital, if we believe that your risk justifies that. And that's medical decision-making 101. And so that's why it would seem there's an even better argument to people to say, look, it's not just, don't just look at it in a vacuum. Look at it as, what is the opportunity cost? What is the cost of doing nothing, right? You're an economist, so you know opportunity cost. And
just play one on TV, but.
So there's my long answer to your short question.
No, you're
Dr.
right.
Shah,
Yeah.
when I go to the drugstore every September and get a flu shot, I don't know who manufactured that vaccine. You've talked about Moderna, Pfizer. There's now the Oxford AstraZeneca one that's coming online that also looks very promising. Will this be up to the clinician to decide which vaccine a patient gets, or explain that to us? How do we know what we're getting?
That's an excellent question. It will depend a lot on availability. Remember, we don't know that they have doses available for everybody immediately for both vaccines. So you may not have a choice, depending on the timing of which one to get. Maybe certain ones are available to you. Maybe another one is or is not. So, and then of course, all the distribution issues that we've heard about in the press.
Sure.
So they, generally, I would say, yes, absolutely. You need to speak to your provider and ask, what are the possible side effects? What can I expect? And there are some. So what I mean by that is they're not serious side effects. They are minor side effects, and especially with the second shot with Pfizer, it'll kind of hit you for a couple of days. You'll feel that fluish sensation of weakness and fatigue. And those are the reports we've kind of heard. So you will feel a little under the weather for just a couple days as your immune system kicks in and fights off this thing that you've already been exposed to once. And so that, I'd say talking to your doctor and having that relationship is key to that, because I really want people to feel that there is trust in how we do these things and how we give these things out. As we know, we've seen a lot of controversy in the last few years about vaccines that we hadn't seen in decades prior. And I think that some of that in my own practice, I'll tell you from my own personal experience, has to do with talking to people to help them understand what exactly they're getting, who made it, what's in it, and what are the possibilities that might happen after that. That conversation helps to engender a lot of trust in the people receiving those things. And I think that that's a crucial part of the practice of medicine as a whole. So I hope that that's kind of how we will approach it.
Transparency seems to be so important here. I mean, from this conversation, if I'm just an average citizen, should I be eager to get a treatment once it has the requisite FDA authorization? What would your general recommendation be?
My general recommendation would be yes. The risk of the vaccine is far, far, far less, orders of magnitude less than the risk of getting a coronavirus infection and then hurting yourself or somebody else around you.
So you've been on the front lines of this since day one, Doctor. Yeah. Can you maybe just take us through where we are now, where we started, and where are we?
Oh, absolutely. So when the pandemic first started, we started hearing about this. It was not on our shores. It seemed to be somewhat foreign. I think people were kind of unfamiliar with what it was. It eventually made its way to the United States. And of course, over the course of the last 10 months, we have experienced a much harder course than many of the other countries have. Over the summer, especially here in the state of Arizona, we saw a massive spike. It went from, we were at about, started at about 10 cases, and then it went to like 50 to 100 cases per day, quickly to 400, quickly then to a peak of about 5,000 cases. During that time, we did implement a whole lot of measures through the governor's executive orders to try to bring the situation more under control. And with everything that we had done, we did bring that down. Many people debate what it was specifically that caused it to come down. Was it the masks? Was it the distancing? Was it the awareness, generally speaking? Some of the clues are in the demographics. As we know, some 60% of people, 62% of people who got this are under the age of 45. We know that the risk to people younger is much less, and the risk to people much older is much greater. That everybody knows that. So people are individually also changing their behavior, and also we are putting in place policies to protect specifically seniors. I mean, most of the senior care facilities that we know have taken extraordinary measures to make sure that their population particularly is safe. So a lot of that helped us bring it down, and it stayed down for a while. And over the last 2 to 3 weeks, we have seen a real rise in cases to the point where it is becoming now, I believe, a true second wave. I had originally said myself in my postings, my speech, that I didn't think that a second wave could be as large as the first wave. I thought that, perhaps given our experiences from before, awareness and everything that we had put in place, we would probably see a wave, but probably wouldn't see a wave with a peak as greater. But we are rapidly, I may be proven wrong, we are rapidly approaching that point where that peak is reaching pretty high levels. If you look at the ADHS website today, we've got, I think, over 3,000 cases reported today. So what does that again translate into? Why does that matter? If the vast majority of these people, or I should say the majority of people, are under 45, and again, most of them, not all of them, but most of them will be okay, what's the problem? The problem is, again, they're spreading it to people that are more at risk, and that causes hospitalizations. A percentage of that will end up in the ICU. We only have so many ICU beds. Back in July, we reached a pretty critical point. We were at 91% occupancy with all of our ICU beds. And that's when you really see a societal problem where we have crisis standards of care. People will make decisions saying you live and you die because of not having space. That's a nightmare scenario we don't want to end up in. And again, we are seeing, looking at the ADHS website data, you're seeing a rise again in ICU usage by COVID patients, hospitalizations. And so we would then have to think again about getting ahead of this with mitigation measures. And that's kind of the lay of the land as I see it.
How about on the therapeutic side? I mean, you don't want to get this at any period of time, but my understanding is that there's some treatments out there that can be helpful, but what's your experience?
Now, I'm not an intensivist, I'm an emergency physician, and most of what we do for people in the ER is sort out who needs to be admitted and who needs to go home.
Okay.
A lot of that is determination is made on what are their vital signs, specifically the pulse oximetry. So if your oxygen levels are very, very low, we're going to recommend you stay in the hospital because your course is probably going to be more complicated. Otherwise, we do, unless you've got some other factors that make your situation worse, we'll probably end up sending you home. The folks that do go inpatient and eventually end up in the ICU are treated by either hospitalists or by intensivists. And my colleagues in those two fields have made some impressive gains in terms of how to treat. Again, you don't want to end up in this area because the mortality rates are still pretty high. When I say high from a medical perspective, we're still talking in the 25 to 50% range, something in that range if you end up hospitalized or in the ICU. Those are not great numbers. You don't want those odds. But nonetheless, they've brought it down from what we had before. And a few of the strategies that we've seen, dexamethasone in a really good trial showed some promise in moderate to severe case, not necessarily mild case, of helping people. There's a drug called remdesivir. Again, it's being used in the sicker patients and to some effect from what we understand. Convalescent plasma, what that is people who have recovered are making antibodies to this virus. You can take those antibodies and put them in another person and that'll mop it up a little bit better. So we've got that chain. I think, Glenn, in fact, you and I kind of talked about that earlier this summer about getting that chain sort of sorted so that people have more access to convalescent plasma. And then finally, the other one is proning. So, flipping people over, believe it or not, seems to make some difference. And when you put them back and forth, it allows different areas of the lung to aerate, and therefore you're seeing some better results. So we're seeing that the mortality, as we get better at this, the mortality rate is dropping. But don't get me wrong, a lot of people are still dying of this, and we're still seeing thousands of deaths in the United States every single day.
On the testing and contact tracing side, a lot more tests today than what we had at the peak, and we don't seem to see the visuals of lines and things like that, and some better tests where you don't necessarily need to get something jammed up your schnoz. They have bit tests and even rapid tests that may not be as accurate. Would just love your thoughts on testing, contact tracing, where we are, and what else we should be doing.
I've had that. As part of the study, I've had it jammed up my schnoz. Not pleasant. If you do have to have it, I suggest you just breathe through it. Don't hold your breath. It's actually worse. There's a little tip for anybody getting that test.
Okay, good to know.
We are way better. I mean, two big things that have come out of this. Number one, in the summer we did, like I said, we managed to get through that peak without reaching crisis standards of care on a widespread. That's a success. I want people to understand that, right? As a society, everything we did paid off. I hope everybody understands that this collective action and understanding how it works and doing what we can works. It helped us, quite frankly, thread the needle, and we just got over the curve, and we had some slight excess capacity left, and we didn't have to make those hard decisions that they did in other places like that. That's a success for us. And then when it comes to the other big success, like we've had now a lot of time, and tests are now a lot more available than they ever used to be. Over the summer, we saw as the supply chain for reagents and the machines and everything else that goes into the testing was strained. We saw that some of our tests, at least where I work, were coming back in 10 to 14 days after we had sent it, which I'm sorry, is practically useless. There's no point in even sending a test. So we would just tell people, look, I'm sorry, but it's not going to come back in time. You have to go home and self-quarantine, and that's the only thing you can really do. That has dramatically changed. Now where I work, usually you're looking at 1 to 2 days. And so I consider that a success, that even though it's not always on the front page of the paper, people behind the scenes have been working really hard to develop more tests, quicker tests. I heard that about the saliva test and the at-home test. Again, I can't vouch for any of those. Those have to be, you have to look at the manufacturer and the data and everything like that. But we have made a lot more tests, a lot more available today than we have had to this point. So I'm really, really happy about that. Then coming to contact tracing, I wish I had better news on that front with regard to our like what we have experienced so far. Unfortunately, I just don't think that we did that in a very robust, comprehensive way that really would make a difference the way that I think that some of the other countries did who had experience with contact tracing. It requires a lot of people. It requires manpower, effort, and execution. And I'm going to be straight, that didn't really happen here based on our resources and everything else we did. It's been harder. I think one of the exciting things that Glenn, I shared with you just a few days ago is that there is a group of people out there who have gone live now in about 16 states and more to quickly follow. This is the COVID Tech Task Force. They know that they can use some really common, easy technology, which is found in your cell phone, low energy Bluetooth technology. It can, without privacy concerns, without sharing it to some central server as to where you are, it can tell whether there's another phone nearby. And if you voluntarily mark yourself as positive, it can go back, look back 14 days, find all the people that you were close to for a certain amount of time at a certain distance and notify them. And so what it would take would be eventually for everybody to turn it on in their phones. If you look at your Apple phone right now, it actually has the exposure notification in most of the iOSs. In the Android version, you do have to download that app. But downloading it voluntarily, opting in, will also help us do contact tracing in a fast, free, and technologically savvy and efficient way that is also maintains privacy. So there's some hope.
I have that on my iPhone right now.
Yeah, I believe you do. If you have updated your iOS and you go to, if you go to the settings, just go to the settings tab and go down. You will see under, like it says, general, control center, et cetera, emergency. You'll see exposure notifications. And if you go in there, you can actually turn it on from there. Now, the Arizona Department of Public Health, Department of Health Services has a part to play in that because we don't want false positives, people just reporting that they have COVID when they don't. We will have some control on that so you can't just put in your positive. And cause a lot of alarm when it's not necessary. So this, in the state of Arizona, that still needs to be turned on at a state level, and those discussions are ongoing.
Excellent.
Good stuff.
Dr. Shah, you've been seeing this in the emergency room now for a few months. When the patient presents themselves, do you know that this individual is likely COVID positive, or could it be influenza? Could it be valley fever? And if so, you mentioned you need to give a test. You talked about it a little bit, but talk about that turnaround time and whether you know it now when this individual walks into the emergency room.
very often we know. They're giving you all the classic signs and symptoms. Sometimes they say that they know of somebody who is exposed. Sometimes they don't. It's not obvious in all cases, but in the sicker people, it's not too much of a stretch of the imagination that they're in there and this is probably the diagnosis.
Yeah.
I have some tools at my disposal. I sometimes get chest x-rays, and the chest x-ray is not a great tool, but it's a tool, and sometimes will show some of the lesions of COVID, which are peripheral and bilateral. So you see it in both lungs and you see it more on the periphery. Again, much of this doesn't affect my decision making as far as should you be in the hospital or not. The decision to hospitalize somebody or institute further treatment. Remember, for the mild cases, there's almost no real treatment. It's just symptomatic. So go home, TLC, Motrin or Tylenol. Just keep yourself hydrated and do well. And if you feel short of breath or otherwise really worse, come back and we'll reevaluate you at that time. One of our bright dividing lines is the idea of the pulse ox being low. So there's a pulse oximeter, which you can buy at Walgreens for $20, and you put it on your finger and it'll check your oxygen percentage. If that percentage drops below a certain level, for most people, you should be above 94%. If you are 92 to 94, that's somewhere in the gray zone. But if you're less than 92%, I think most of us would say, aha, there's something going on, because a healthy person really shouldn't be less than 92, unless you have something else going on that we don't know, like COPD or asthma or something else that causes that. So, the test, I think what you're bringing up is that, I can send the test, but the test won't come back for 2 days. But now I've still got this person in front of me
Right.
that I'm dealing with. But as a physician, the diagnosis is really made clinically. And the treatment, the decision to hospitalize or go further is also made clinically. So I don't actually need the test. Now, if I want some confirmation right then and there as to whether or not this person is COVID positive or not, I do have at my disposal a CT scan of the chest with no contrast. It's a pretty good test. I mean, you do the scan, and if you're really concerned, and I don't have a study on radiology for this, but to be honest, it's pretty obvious when somebody has COVID, because you see on the CT scan, again, the bilateral, they call it the ground glass opacity, that's the medical term. And you see other things like they call it crazy paving, and they call it, consolidation within the lungs. So you see these classic things, and we've seen them so often now on these CT scans. In some cases, entire lungs destroyed, and in some cases, just the beginnings, and it's very mild cases. So it helps us. I mean, this is how doctors make decisions in the emergency department.
I see. You've been really generous with your time. So just a couple more questions here. 'Tis the season. It's Thanksgiving. People are talking about, well, we're not going to do the usual Thanksgiving. Some are going to do it in the backyard. Some are going to have grandma eat turkey in the garage. What are your thoughts about family gatherings and safe ways to do it, or maybe not do it at all? You tell us.
I don't think I could get away with that one, Garrick. But
Okay,
anyway,
well.
doctor.
Here comes the Grinch.
I know, less is better. I can't sugarcoat that for you. As a physician, I would be irresponsible to say anything other than that, right? There's more risk and there's less risk. If you choose to distance and stay away from one another and have it virtually and eat your food, over Zoom, that is a way of staying safer. If you get together and you do it outside, that's better than indoors. If you stay physically separated compared to sitting all close together, that's even better. If you all decide to self-quarantine for 14 days and not encounter anybody and get tested, and you're negative and you have come in contact with nobody, that's another way. That's a strategy, I guess, that you could think of, like, hey, wait a minute, I want to keep my relatives that are older safe. Right. The thing that I worry about, again, is that when these Thanksgivings happen, families get together that are multi-generational. It's the time in our, as right. Most of us do, I go see my parents. I see cousins and friends and aunts and uncles who are of a different generation than I am. I'm less than 45 and I don't have any medical problems. I'm on the lower end. But I compared to others, have a higher risk of being exposed, of course, because of my job. So I have to weigh that. I personally had thought to myself, perhaps if the conditions were right, maybe I could make my way over to my parents' place, but I don't think I'll be doing that this year, just because I can't take the risk of infecting them, even accidentally, and even if it's a small risk, that they would then come to harm because of me and my actions, and I can't. That's not comfortable for me. So less is more. I think that's kind of the message we've been talking to people about the entire time. The less we can do, and we can get over this pandemic, I think is better. I tell you what also just kind of comes to my mind right away is that how awful would it be if something happened to your parents or to the people you loved, and the vaccine is going to be available in the next 3 to 4 weeks, and you could have just waited. We're at the end of a marathon, and it's kind of like you're at 26 miles, you have 0.2 to go, and it's kind of like, well, now you want to cause a problem. That would seem like harm in vain. That would seem like something that the end is in sight. We think that with widespread vaccine use that will be coming hopefully soon, we will really put an end to this. The light is really there at the end of the tunnel. I hope people understand how hard people have worked and how much time, effort, and risk and sweat and tears went into producing this thing, knowledge and just made possible by so many of our the companies that are in this, and also all the stakeholders. I want to say, like, the governments and across the world. It's been a worldwide effort to make this happen. So let's just hang on a little bit longer.
Yeah, well, it's good advice. Dr. Shah, you are what we consider a frontline medical worker because you work in an emergency room. So when we talk about who goes first in the vaccine, it's people like you who go first. What about Joe Sweatsock here, who's talking to you? When do we go? Where do we fall in that order?
Well, Joe, it really would depend on a lot of other factors. So the guidance that has come out so far has really been that what we've seen bounced around as far as ideas, and the guidance that we've seen so far is that yes, healthcare workers, frontline personnel would be the first to receive it, and the answer for that is obvious. The logic is obvious because those people could then spread it to other people, and you can't have that, right? So that's great. But I would say the next most vulnerable group would be the seniors. And so I think and perhaps the very vulnerable in terms of medical conditions, those people as well. So you'd have to think about, if you wanted to save as many lives as possible with this vaccine, how would you go about doing it? And I think that those risk factors would then guide us to figure out when. So Joe, if you're 80 years old, I believe that you should actually move up in line. And if you're 17 years old, you probably are at the lowest priority.
Got it. All right. Glenn will get a special category for chamber executives for you, so don't worry about it. We're working on it.
Oh, you're muted, I think.
Glenn, do you turn yourself off? Oh no. Well, should we talk over him?
Yeah, I don't know if he can hear us or not, but
Glenn. Oh.
Apparently, I had to. I'm sorry. I had to censor my remarks. A call came in. A good friend, actually, who I'll call in a few moments. I just wanted to thank you. You've been very generous to myself and the chamber team and the general public throughout this pandemic, sharing your experiences. And I love how you summarize things. Where the light really is at the end of the tunnel. Let's double down, be more vigilant than ever, and very, very soon we're going to wake up, and it's going to be a lot better out there. But let's be smart out there.
I thank you. Yeah, I see. I hope you guys do too. There's a lot of hope from these two vaccines coming out and having the success. I mean, just the fact that we had a 95% efficacy on two vaccines should cause the entire world to go up in a big whoop.
Yep.
I love it. I love it. And
Yeah.
and I also just want to say for the record, Doctor, for what it's worth, you have the best background I think I've ever seen for a Zoom call. So I'm going to have to figure out how to reverse engineer something similar. But
I'd be happy to share that as long as if you look really closely, if you look at the pictures back there, that's not my family at all.
Fair enough.
well, it looks really good. And again, Doctor, just thank you for being so generous with your time tonight. We're going to get this out. A lot of great information to keep the good people of Arizona safe. Thank you.
My pleasure. Thank you for having me.